And how many people here, I guess before we start, how many people here have actually suffered an ankle fracture in the past? And when you think about the ankle and the structures that we can break when we have an ankle fracture, the ankle is broken up into three main parts. And my laser isn't working too well, but the first part that we're thinking of is the outer knuckle of the ankle bone called the fibula. And that's the bone that most often when the ankle rolls can break or the ligaments can tear off of. The inner ankle bone or the inner knuckle is called the medial malleolus, and that comes off of your shin bone called the tibia. And then the most critical part of the ankle, which is called the talus, is the third bone. And the talus is the bone that basically allows your ankle to go around in a circle and up and down. That's kind of the pivot point of the joint. And what happens is when the ankle breaks, one of these two bones, or both, will break, and the talus will slide back and forth. Now, the talus is important because the talus has three sides of cartilage on it. The top of the ankle of the talus has cartilage on it, and the sides of the talus have cartilage, and they meet the bottom of the tibia, which also has cartilage on it. And the most common reason why people will get ankle arthritis is because of an ankle fracture. And what happens is when that ankle breaks, the bones break, the talus shifts either in or out or back and forth. And what happens is instead of that ankle gliding, those bones shear. And when those bones shear, it can cause the cartilage to break down and wear away. And as we know, cartilage or arthritis is defined as a loss of cartilage in the joint. So instead of having this nice classic space where the ankle can go up and down and around, that joint space gets smaller and smaller and smaller. And when that gets smaller, the ankle grinds. We get more friction, we get more cartilage that wears away, and we get pain. And when that pain starts to set in, different things can occur. We can have an ankle that will just become very grindy, and you'll hear it snap, crackle, pop. You'll hear it, you'll feel some fluid pop back and forth. It'll swell. You'll sometimes see an ankle that the foot and the ankle will flatten out. The heel will roll in. The foot will turn out, and you have a hard time walking because the foot is in a position where it's bowed almost. You'll have a situation where the ankle just is rock solid and stiff. It won't move. When you try to bring the ankle up, the bone blocks it. So those are many situations where an ankle can become arthritic, and it's the way that the anatomy is affected that dictates which situation you're going to have. Is it the bones that are damaged? Is it the bones and the ligaments? Or is it the bones, ligaments, and the tendons? And any of those scenarios will dictate to a surgeon what we can do to help you feel better. So as I mentioned, the main causes of arthritis, especially the ankle, is for the most part those who suffered from an ankle fracture. But if you haven't had an ankle fracture and you have ankle arthritis, you can either blame your parents because of the hereditary factors. You can blame your boss because of the job, or you can just, unfortunately, you can just get it because sometimes you have an immune deficiency like rheumatoid arthritis or psoriatic arthritis or things of that nature. But typically the wear and tear associated with the position that you may be working in for many years, the sports that you played, the activities that you do on a routine basis, and sometimes good old-fashioned hereditary factors. What is your predisposition to getting arthritis, and how does that cause you to get a loss of joint space? And that's why one of our busiest things that we do in this institution is the knee replacement. Many people don't have knee fractures, but what happens is over years the knee wears and the wear and tear associated with the knee is what causes the knee to break down, and that's why we have to replace it. Well, what happens is we've got different proteins and different structures in our cartilage that our parents pass down to us, which will dictate how well that cartilage is going to wear and tear. And some of us will have an ankle fracture and never get a drop of arthritis, while the overwhelming majority of us that have an ankle fracture, because of our joint structure, it will break down and it will become, at least to some degree, arthritic. So there are three stages. In medicine, we tend to classify everything. The classification and our understanding of the level of that arthritis is what dictates the approach that we take to treating it. And in this instance, there are three stages primarily of arthritis. Stage 1, Stage 2, and Stage 3, creatively enough named. And the Stage 1 arthritis is that early stage in arthritis. That's a situation where you've got an ankle that basically is just inflamed on the inside. You can see this is an arthroscopic picture of the ankle joint, and this is the cartilage. See this yellowish, whitish yellow tissue here? This is cartilage, and this is a cartilage that's got a little wear and tear to it because it should be vibrant, bright white. It should look like a white egg. And when it starts to yellow and brown, that tells us that cartilage has gotten a little bit more unhealthy. It tells us that it's just getting ready to start to wear away a little bit. And you can see here that we've got a lot of what we call hemorrhagic synovitis. And what that is the tissue around the ankle that's holding the bones together. When you crack your knuckles, you hear that tissue. That tissue is a little torn. It's a little frayed. It pinches in the joint. So when the ankle goes up and down, that tissue will get irritated because the bones catch it and make it inflamed. You know, this is a much easier type of arthritis or stage of arthritis to treat than the patient who you saw here, who arguably may have went from this nice healthy ankle to this joint down the road. This is an end stage, a Stage 3 arthritis. And you can see here, there's no more joint space left. The bones are grinding, they're unhealthy. The bones don't look nearly as healthy here as they do here. And because of that, you know, we've got to take a different approach for this individual than we did for the patient on this slide, where we were able to go in arthroscopically and just clean it up. And it's almost like changing the oil in a car. You kind of change the filters and you clean out the joint and get everything going again, and you're able to walk a lot more comfortably. Sometimes cortisone injections can make that feel better. Physical therapy is an important part, especially after an arthroscopic cleanup, because the therapy, the range of motion, getting that gliding motion of the joint back to where it needs to be is an important part. So I always tell our patients that in many instances, the therapist is as important, or if not more important, than what the surgeon is doing. Because the arthroscopy is very easy. We can go in and clean that out quite simply. But the therapist who's going to work you afterwards is the important part, because they got to get that joint moving again. And you know, so that's a great example of like a Stage 1 arthritis. A Stage 2 arthritis is something that's much, much more extensive. This is where we've actually had a piece of cartilage and sometimes bone underneath the cartilage has broken away, and it's really created a significant loss in the joint. So if we think of the joint as this desk, imagine if, say, 30 or 40 or 50% of this desk had a chunk of cartilage taken out of it. The joint has started to break down. The joint space has become more narrowed. The motion isn't as good. The pain is significant. It's getting more and more significant. Typically, patients that have like a Stage 2 arthritis, when they wake up in the morning, it'll take them a good 10 minutes or so to get going. And once they get going, they're okay. But once they stop and try to get back up again, it's a tough situation again. You know, these are things where we'll start to develop some bone spurs around the joint. Sometimes if you put your hand on the ankle, you'll feel some bumps, and you know, you'll feel some little peaks and valleys on the joint. That is a classic example of like a grade 2 arthritis. And when you see here on the picture, this patient's joint space is a little bit more narrow, but they've also lost some significant amount of cartilage here. And well, on the MRI picture, it doesn't look like a lot. In person, that's about 30% of the joint that's missing. And it's completely bone on that portion. Yet the rest of the cartilage is still okay. But over time, unfortunately, because arthritis, you can't cure it. You can only hope to stop the progression. Or you can only hope to slow the progression. That will progress over time, even if we do some of the things that we try to do for arthritis. And some of those things are some viscosupplementation. You may have had this yourself, or have friends that had these shots in the knee, where they talk about the fluid that they get from chicken feed and things of that nature. These are lubricants that we're able to add into the joint that in the ankle it's not FDA approved, but sometimes there are ways where we can work around that, where it can give the patient some benefits. Sometimes we have to go in and remove the spurs. We have to file them down and give the ankle the ability to move better. Sometimes an arthroscopy, again, like the last time, but it's a little bit more extensive, can be helpful. And sometimes, you know, a combination of all of those things is used to help the patient when they have a Stage 2 arthritis get through it. And finally, grade 3 arthritis. Now, grade 3 arthritis, you can see the gentleman whose ankle is in this slide, you can see this is a much different picture than the pictures I showed you before. This joint has become to the point where it is bone on bone, and it is actually starting to deform. The ankle is actually, the bones are starting to bend in positions that that bone isn't meant to bend in. And you can see there's no space here at all. You have spurs here, you have spurs here. The bone is very chalky looking, it's very unhealthy. This is a patient where all of the stuff that I talked to you about before typically doesn't help. We can give this individual a shot, and it may help for a month, but typically they come back in and go, yeah, I felt great for a day, but guess what? It's back to where it was. We can try therapy, we can do some bracing, but all in all, this is a patient when they step down, the bones literally grind, and it causes pain. It typically is very difficult for the ankle to move up and down at all, and so when that happens, when they walk, there's a lot of grinding and what we call shear force, meaning the friction in that joint is so significant, it makes everything around it inflamed. And when that occurs, patients typically come to our institution and they say, I need to do something because I'm waving the white flag, I give up, I need to get on with my life, and this ankle is just not helping me do that. And in those instances, we do one of two things. We either do an ankle fusion or we do an ankle replacement. And we talked a little bit about the basics of arthritis earlier. The crux of this talk, for the most part, is really what can we do when we have these advanced situations? Because I find that we all have family or friends or people that we've associated with who have had arthroscopy. We all know people who have gotten a cortisone injection, and those are a little bit better understood. But when people have an ankle fusion or people have an ankle replacement, they typically say that if I have an ankle fusion, I don't think I'm going to be able to walk as well. Or if I have an ankle replacement, we didn't know we made ankle replacements, who knew? So, to eliminate that confusion, I want to spend the majority of what we're going to talk about today on those two things. So, to first start about ankle fusion, the ankle fusion is typically where we'll lock the tibia and the talus together. So the ankle is literally held at 90 degrees. And while that seems like it can be problematic, and we'll do that with, as you can see, a combination of plate screws, or as some people we've worked on have rods that go inside the bone up into their leg to make that bone fuse together and become solid. The purpose of it is when the ankle is so, when the cartilage is too far gone to repair, and when the joint space is so damaged that we can lock that ankle up at 90 degrees, and when the patient steps down, instead of having that little friction and micromotion that causes all that pain, the patient is able to ambulate off of that ankle pain-free, and they can propulse. Now, while it does stiffen the ankle to the point where the ankle's at 90 degrees, in many situations, if the rest of the foot doesn't have a lot of arthritis to it, the other joints can make up for that loss of motion. I had a nurse that worked with me for several years who had an ankle fusion when she was young because of a bad car accident that she was in. She could stand on her tiptoes. Her ankle would not move at all, but the rest of her foot would make up for that loss. Now, when you have arthritis in the other joints, that makes it a little bit more of a challenging situation. And unfortunately with that, we have to supplement it with modifying your shoes or a brace or things of that nature. But locking the ankle joint up when it's very arthritic can be a very positive thing when the ankle is not a candidate for a replacement and when the pain is too severe that if you leave it alone, it's just not going to be successful. So again, what we do is we actually will take these bones and we will screw these bones together in varying different combinations and configurations. And by utilizing those screws, we'll be able to get that patient pain-free because those bones will actually grow together. And what will happen is that patient will be able to push off of that foot, and the grinding that occurred that caused the pain will be eliminated. In the 1970s, there were some surgeons that worked overseas that decided that they wanted to come up with a way to replace the ankle. And the first ankle or the first knee replacement in the United States was in the mid-1970s. It was designed by a guy named Leo Whiteside, and it really caught fire here. I mean, obviously, as you know, we've all know people in our lives that have had knee replacements, I'm sure. And but at the same time, there were some surgeons over in Europe, and particularly Germany, that were working on ankle replacements. And basically back in the late 80s, early 90s in this country, the first generation of ankle replacements became more popular, and it was designed by a surgeon in the Dakotas, and the implant is still used today to some degree, and it's the one that you see on the picture here. But this is designed so that way for the patients that still have good anatomy but still are very arthritic, we can actually remove the ankle joint, and instead of fusing it together to make it stiff, we can replace the bad parts and allow the patient to have range of motion and the ability to move it again. Now, there are situations where patients have arthritis that they're just quite frankly not a candidate for a fusion or for a replacement. Some people just can't get a replacement because the bone quality isn't good enough, because the joints around it are too arthritic, because the amount of bowing they have in their legs, and things of that. All of those things play into factors as to why we can't do an ankle replacement on some patients, but we can do it on others. But what it does is by removing those arthritic bones in those joints, we're able to put in the new parts and allow that ankle to function biomechanically the way it was designed to. This is a current design of what an ankle replacement looks like today. You can see we remove a portion of the tibia, we remove a portion of the talus, and then we put in a metal tibial component and a metal talar component. The space in the middle is actually a plastic piece that you don't see on the x-ray that acts as a shock absorbing bearing so that the ankle can go up and down, and when you step, it absorbs the pressure and the shock of walking to preserve the life of the implant. The implants that we use are specific to the patient. There are 2 or 3 main implants that I'll use, and I typically will choose the one that works best for your body. The design of them varies specifically for different features, and those features, again, we tailor to what your needs are as a patient. But the idea, again, is to get rid of the arthritic bones and allow the joints to go up and down, around in a circle, and to function properly, and for the patient to ambulate without a bracing or without any sort of assistance. The picture on the left is an implant that is very current and very progressive, but you can see it's very different than the implant on the right. This implant gives the patient a little bit more stability when they need it. That implant's a little bit more low profile just in case there's situations where the bone can't accommodate one or the other. Again, these are the things that we look at when we're deciding whether or not which prosthetic to utilize in your foot or ankle. It is something that has in the last 5 to 10 years has changed dramatically in musculoskeletal surgery. We have found that the technology in ankle replacements has really gone through a steep improvement, I would say starting back in 2002 to 2004, and has gotten to the point today where I consider them to be tremendous implants. There was a time when I joined the practice in 2004 where if I had a family member that needed an ankle replacement, I would not have done it because they were not good enough. Today, if I had a family member that needed an ankle replacement, I would have no reservations about putting one in because the technology has just gotten that good. Much like in the 80s when the knee technology kind of went through the same boom, the ankle technology has gone through that boom in the last decade. And it's an exciting thing to see because it's really giving a lot of patients who are, for whatever reason, opposed to having a fusion done, another option where they can change their quality of life. And what's changed the most about these prosthetics is the fact that we've got a situation where we can now utilize these different targeting devices, like you'll see here, where we have the template for the ankle, and we've got this wire that's actually not in the bone, but behind the bone, and we can utilize that as our way to target and align the device. And that allows us to have reproducible results every time we put the prosthetic in. It takes the variability out of it, which is something we didn't have in 2002 and in the early 2000s when I started to learn how to do ankle replacements. Because we had to do freehanding cuts all the time, and you had to kind of guesstimate here and guesstimate there. Now you don't have that. We've got exact duplication of the prosthetic every time we need to do that. And because of it, we've got patients that are much happier. We've got implants that are lasting much, much longer. And we've got patients that are able to go and do things that they weren't able to do before they had the prosthetic put in. So those things are exciting to see when you think about the kind of opportunity that the prosthetic gives you. So typically, who is a candidate? Well, typically, and I say typically because we've done patients who are younger than 50. In fact, I've done patients who are younger than 40 for certain reasons. But for the most part, our candidates are patients who are over 50, who are typically not diabetic, and if they are diabetic, it does not necessarily exclude you completely, but what we have to do is get a good understanding of how your sugar runs and how you're controlling your sugar, because we don't want to get in a situation where we do more harm than good. But for the most part, it's a patient who's over 50, who's a non-smoker, non-diabetic, who has end-stage arthritis that has good blood flow to the extremity. We look at the amount of curvature to the leg. If there's more bowing in the shin bone than between 7 and 10 degrees, we'll typically not do an ankle replacement. We'll typically do a fusion. But for the most part, patients who have end-stage arthritis, who have a straight leg and have good blood flow, you're a patient that we'll typically consider. All patients before, during their evaluation, if they're a candidate for an ankle replacement, we'll get an MRI done or a CAT scan done, depending on your particular needs, to make sure the inside of the bone is as healthy as the outside of the bone. The X-rays only show us one part of the picture. The advanced image can give us a better idea of what that looks like. Typically, our patients are candidates. We do not like our patients to be smokers, and if they are smokers, we do our best to get them to quit. And we don't do it necessarily for the prosthetic. We do it for the skin healing after the surgery. The incision to do an ankle replacement is on the front of the ankle. The skin on the front of the ankle is very thin. It's the farthest away from the heart, and it just kind of heals crummy compared to all the other skin in the body. So when you're a smoker, the nicotine will actually make the arteries and the little capillaries that go into the skin very constricted. So the cells for the healing process don't get through them as well. So smokers will actually have a little bit of delayed healing with their skin compared to those who are non-smokers. So when we can get the nicotine out of the system and keep patients off the cigarettes, at least in the period of time for the skin to heal, we find that they have better outcomes. A lot of patients will feel like I'm giving them a lecture, when in fact I'm not giving them a lecture at all. I just want their skin to heal so that they don't have to come in every week and we don't have to do dressing changes. Because the faster your skin heals, typically the faster we can get you on your feet in a sneaker and get you walking into physical therapy. This is an example of a device that we actually put a patient's foot in and leg in while we're operating on them. And you can see it's got a lot of knobs and a lot of twists and turns on it. And this is so we can actually dial in the anatomy of the patient so that your ankle and your ankle and your ankle and your ankle are actually going to go in very differently, because we're going to tailor that device to your anatomy to make sure that it's tailored to your needs. That is probably one of the best innovations of ankle replacement surgery in the last 10 years, hands down. There's probably not even a close competitor for the technology there. So we've got a great opportunity to help those patients who are at the point where they're bone-on-bone loss and they're just not feeling comfortable when they're ambulating. So patients, when they come in, will typically ask us, how long do they last? Well, the simple answer is, the metal, if in good position and doesn't have a lot of stress on it from a bone that doesn't have great shape to it, can last a lifetime. The plastic piece, that polyethylene component, which is the shock absorber, will typically have a lifetime of 8 to 12 years. Now, patients who have it for that long, we typically have our patients come in once a year for an x-ray, and what we do is we measure that space to see if that poly component is wearing away. Once it starts to wear the way and the joint gets a little unstable at that time period, typically around a decade, sometimes a procedure is done called a poly exchange, where we have to make an incision, remove that plastic component, and pop a new one in. Again, it's kind of like getting a lube job done in your car. We just want to replace that worn out part, put a new one in, and get you going again. There are instances which are more rare because, again, the technology's gotten much better with the ability for the implant to go in, where the bone around the implant can loosen and sometimes the implant can shift, especially if you slip on of ice or something like that, or if you were involved in a motor vehicle accident, which would have normally broken your ankle. An ankle replacement isn't going to prevent that ankle from breaking. If you're going to get hit hard by a car and that ankle's going to break, the ankle is going to break whether the implant's in there or not. And if those things happen, then so be it. We fix it, and we have to do what we have to do to make it better. But for the most part, the ankles, the plastic inside them do have a lifetime of 8 to 12 years, and as long as the patient takes good care of their ankle, the metal components can certainly last a lifetime, God willing. So. That's, and the position of that implant when it goes in and the position of the leg and the patient's anatomy are very important factors. So that's why when we look at patients, we do some of these MRIs and things of that so that we get a firm understanding of what the patient can expect after the procedure. So I've told you about the good, now I'll tell you about the bad. So what can go wrong? So certainly after any type of musculoskeletal surgery, there are certainly complications that can occur. And typically in orthopedics or any type of joint surgery, we'll have a 1% chance of infection. One patient out of 100 can get an infection. Of those one patient out of 100 that can get an infection, most of the infections are superficial and resolved with oral antibiotics. If the infection were to be deep, the patient would have to have the wound, the area washed out. And there are situations where sometimes the replacement has to be removed and a spacer, an antibiotic spacer, has to be put in. My father-in-law's hip just went through that exact same thing where he had his hip replaced, the hip got infected, they had to go in and pull out his hip, put a spacer in, he had to leave the spacer in for 3 or 4, 6 months, and then they put a new prosthetic in after the infection's resolved. Typically we tell our patients, if you see something that's red and it doesn't look right, come in. This is something that you don't want to mess around with. But again, the infection rate is, again, 1%. Blood clot risk is also about 1%. We do put our patients on blood thinners after the procedure. You'll be on those for about 2 weeks after the procedure. And we tell our patients to inspect their calf muscle if they have any pain with squeezing the calf or anything in the post-op period to get an ultrasound done. But again, the blood clot risk is about 1% as well. Implant loosening and subsidence is something that used to happen all the time. The technology and the engineering of the metal and the types of metals that we used have, I don't want to say have completely eliminated it, but have reduced it so that it is far less even than the risk of an infection or of blood clot. The risk of loosening of the implant is down to a half or a third of a percent. It is very loose. The technology of the metal, because the bone now can grow around and into the metal because of the way it's designed, has made these implants rock solid. And sometimes when we have to go in and get them out for various reasons, they don't want to come out because they're so ingrained into the bone, which is a good thing because they become part of your body and you can use them without having to worry about the thing shifting. And then, obviously, as I talked to you about before, the implant or the plastic piece that will wear out, again, anywhere between 8 to 12 years. The knee literature is showing that those implants or those polys can last even up to 20 years now. The engineering of that plastic for the implants that we utilize is such a big business. There are people that just write textbooks alone on the plastic. They don't even talk about the metal that goes around it. They just talk about the plastic. That's how important that the engineering has become and the advances that we've made in the engineering of that plastic. So after the ankle replacement, typically our patients are in a splint for 2 weeks, and you'll be able to get around in a walker or crutches or a wheelchair or a combination of all three. And we leave the ankle wrapped up and the ankle held at 90 degrees for about 2 weeks. Once the ankle's held at 90 degrees for 2 weeks and the skin is healed, once the stitches come out, we tell you that you can start walking immediately that day in a sneaker. We have you walk with assistance in the beginning, but we have you put weight on it. We get you into physical therapy, and the hard part starts. But the hard part is where you get your reward, because that's where you're going to get your muscle strength back. That's where you're going to get the ability to walk heel to toe again. That's where you're going to have the ability to do a lot of different things that you didn't have the ability to do before. And you're going to have to retrain a lot of muscles and ligaments that were not being utilized at all because of your arthritic ankle. You're going to have to retrain those tendons and ligaments and muscles to do the job that they were designed to do. And that typically takes anywhere from 3 to 6 months. Now, does that mean that you'll be in physical therapy for 6 months? No. But that means that we're going to expect you to exercise it and use it and work it out and dedicate some time to making sure that those muscles get strong during that period. Typically, our patients are in therapy for about 3 to 4 months, and then we have them do a home program for another couple months. It is something that, again, you'll be on a blood thinner for about 10 days. And we'll monitor you in the office. In the beginning, we'll see you 1 week after surgery. We'll see you another week after that. Then we typically see you 3 weeks after that, and then we'll see you every month to 6 weeks until you come in, walk in, and go, and look, and I can dance and play golf. We don't allow our patients to run on our implants, but we do allow for golf and walking to play golf. We do allow tennis. We do allow walking for exercise. I have patients that are doing different activities. They hike. They wear hiking boots. There are a lot. I have a gentleman who actually just submitted a DVD who had an ankle replacement done. He's an 8-degree black belt. who is still, he's not kicking anything because I'd have a heart attack, but he's actually doing karate. He teaches karate. He actually goes back and forth from here in Japan, and he's doing everything, and he states he feels better than he ever has. But so I'll let you do things that do have a little impact, but I don't like patients running on their implants because it does just wear it out too fast. So when you think of where you're going to be before and afterwards, and when you think of what the surgery entails, this is not a surgery that is done at every orthopedic office. This is not a procedure that's done at every foot and ankle office. These are procedures that typically are highly specialized. They're typically in a community, maybe one or two doctors in a large community that will do them. So if you do have an ankle that you're considering an ankle replacement on, I encourage you to ask your surgeon a lot of questions. Ask him or her how many they've done. How many systems are they trained in? Why do they do the certain systems that they're doing? You want to talk to your patient, certainly about your surgeon about the risks and complications that he or she had, about the length of the surgery. Typically, our surgeries last about 90 minutes or less. Our hospital stay is a 2-day surgery. A 2-day hospital stay. Typically, you'll stay 2 nights, and after the second night, if you're feeling well, we'll let you go home. Again, you'll be on blood thinners. You want to make sure that that you're following all the typical total joint precautions. You go to the dentist. What happens? Well, we have our patients take. If you don't have a penicillin allergy, you're going to take 2,000 milligrams of amoxicillin before you go to the dentist. The gums are an easy place for bacteria to get in and go to a prosthetic. So you want to make sure after the surgery for 2 to 3 weeks, we have you wear a compression stocking on the other side. You may have seen patients that have a knee surgery, if you've been here before, walking around with the white stockings on their legs. We do those to prevent blood clot risks. So all of those things you want to make sure that your surgeon is certainly aware of and well prepares you for those, certainly for those issues. And then the last thing that we talk about is something even more exciting, which is where we now have the ability to make an implant custom to your ankle. Where the implant that I showed you, we can actually take a CAT scan of your ankle, and we then send it to the company who manufactures these, and they can actually make an implant that is specific to you and your body. And what we're able to do is we're able to cut down the time of surgery. We're able to take the nuances of your particular body and apply that to the ankle replacement. And when we do that, that ankle is as custom to you as it can possibly be. There are some patients who are not a candidate for it. There are some patients who are a candidate for it. That doesn't mean the patients who aren't a candidate for it are not going to have a good outcome, because I've done 125 of the same type of implant that were not custom but tailored to the patient who had wonderful results. But the technology is again evolving, and there are certain situations where we can match the prosthetic up to your anatomy and give you what we feel is even the best chance for a successful outcome. So that's my discussion on ankle replacements. Do you guys have questions? Fire away. Sure.
What's the recovery time on the fusion?
So the fusion's a bit different. The fusion, what we have to do with the idea behind a fusion is we have to take your tibia and your talus and we have to let it fuse together. So when it fuses together, what we have to do is we have to give you the time to allow that to happen. So typically our patients are non-weight bearing on crutches or a walker for 3 months, and then they'll start walking progressively after that and do therapy and everything else. But the therapy but the process for that and the reason for that is because I can't have you walk on the fusion because the bones have to knit together, and if you're walking, it's going to disturb the ability for that to happen.
Did I hear you say that you can have an injection with, like they do with the knees, mm-hmm. with the gel, for lack of a better term? Can they do that with the ankle?
You can do it in the ankle. It's not FDA approved, so we have to work around that. And there are ways that we can do that. But the medicine can go in the joint, and you do a series typically of 3 of those shots. And
it's the same type of.
Same. It's the same exact brand. Yeah, exact same brand. Go ahead.
How often can cortisone injections keep working? I've had 2 done in a 6-month period, and the doctor's suggesting we go for round 3. I'm a little discouraged.
That's a hard question to answer because it all depends on how bad your ankle is on the X-ray. So, I have a patient who wants to have an ankle replacement done who needs one desperately, but it's not the best time for her work-wise with the economy and everything else. Her ankle is shot. The cortisone is not going to cause her cartilage to be more damaged because she has none left. She's bone on bone. I mean, literally, the downside to putting cortisone in there is none because we're not going to hurt anything. Yeah. So I'll typically inject her every 3 months at her request.
I've had no x-rays. Yeah. I've been told they're not necessary.
Oh, dear God. I would advise you to get an x-ray.
That's what I was thinking.
So,
over the years, even as a young kid, I sprained my right ankle so many times. Even I consider not an accident, but I fell, the whole big thing. And now as I'm getting older, it hurts like I don't think I might have arthritis. Could that be caused from the sprain?
There are. So ankle sprains, in fact, this morning I saw a good friend of mine. I play golf. We were on CNN together. Sanjay Gupta came here and did an ankle replacement special on us, and he was the patient that he's a pretty high-level competitive golfer, and he was a patient that was in the video with us, and we became very good friends. And he had an ankle arthritis because of that exact same reason. When he was younger playing sport, his ankles just roll and roll and roll. And what happens, that twisting, again, that shear, every time it rolls, can take some cartilage off, and eventually it wears away. Again, that'd be a situation where an X-ray is certainly very helpful. And if the ankle doesn't look too arthritic, then maybe it's just the fact that your ligaments are no longer rubber bands anymore. Yeah, and that can make you buckle. Yeah.
For the ankle replacement, how long would you be out like for work? When can you return?
Well, it depends what you do. So if you have a job where you sit a lot, or if you're at a desk, then we let our patients certainly go back to work a lot sooner than if somebody who's walking all day long or doing something a little bit more manual. But I've had patients that have had a job where they've do sitting. If you're on your feet constantly, then certainly, I tell our patients, at minimum 4 months.
4 months.
Yeah.
What's the percentage of success early on?
Very good. In fact, we just submitted our data to be published at a journal, and what we looked at our first, we're looking at our first, 85 or 90 joints, and I can tell you that I've had one patient out of those that I've had to pull, that we had to pull the joint out because of an infection. We've had a few patients, I think like 5 patients that have had some like numbness or tingling on the bottom of the foot because of us going in there and pulling and tugging and kind of getting the job done. The overall success rate is, I'd say, probably around 93 to 94% total overall patient satisfaction if you look at the data. Now, I've been in practice here at Coordinated Health since 2004. Before then, I was at my surgical training in Philadelphia. So, I can't tell you what my personal 10-year results are because I'm not quite there yet. But our midterm results are pretty darn good. I would tell you that when I joined this, we learned how to do them when I was training, and I took many, many courses and went all over the place, Europe, you name it, to learn from the best to do these. And when I joined this practice, I didn't do them because the technology was not good. And I could tell you right now, if I didn't think that the patients were doing as well as I liked, I wouldn't do them now. One, the patients that have problems can have problems. Just like a knee replacement patient, once the knee's cut out, if you have a problem with it, it's a problem. And when I could go and do a fusion, and they do great. So but patients do great, and it gives them the ability to do activities that they wouldn't be able to do if they had a fusion. And that's not to say a fusion's horrible. I mean, there are certain situations where the fusion is the best situation for the patient. I mean, he's a great example. Your legs just would not have tolerated an ankle replacement. He would have worn that out in 6 months because of different things that happened with his legs. But they do very, very well, and the technology is just very exciting because it's just gotten so much better.